Sushilji take it from there. Thank you, Sushilji. Thank you for listening.
So let's have a discussion now. Okay, what is it? What are your ideas? What are your thoughts? What can we do to improve this? Anyone wants to say anything?
Please unmute yourself and I'll make some notes. Go ahead.
Yeah, question for Raj. What has been the feedback on the implementation so far? What have been some of the challenges or issues that we need to be aware of if you're going to start a center?
Yeah, feedback is often our Sahayak find little difficulty in operating the software or operating the phone or connectivity. That is the major problem. Once the connection is made, once the patient is there and um, uh, and
Okay, now we can see your face.
sorry about that.
Okay.
So once that technology hurdles, and of course once they become more using it more often, it becomes easier for them to operate. So that's a hardware and software operability is the one problem that we occasionally face. Second problem is that patients sometimes feel that, oh, I really would like to see the doctor in person. But that is a very, very small percentage. Most of the patient, I would say 99% are happy just that they were able to talk to the doctor, see the doctor online, even though it is not that to the 100% satisfaction of in person, but they're happy to receive the care. So other than that, Sundar, there has not been any significant issues that we have found. Of course, remember, it's only in last 2 months that we have really expanded from initial 20 sites to 300 sites. So I'm sure we'll have some logistic issues and that will come. And we are aware of it. I must say, Evolco, one of Evolco's executive chairman is Arjun Malhotra. I'm sure you know all of them.
Yeah.
So Arjun, it is because of Arjun and Amit Kharev, who is the CEO, that they bring in and give us this software and support at a really nominal cost. There are about 200 plus people on the ground, going to the villages, holding hands, training them, and answering any question. Plus, they have about 200 plus doctors at their end who provide the service. Like if Anandpur, if their doctor is busy and don't come, within 20 minutes, their doctor comes and take over. So it's kind of a excellent service organization, and that's why they're so successful. They're also for profit, and they have done more than 10 million consults, and they charge 250 rupees for each consult. So we are getting at their less than 50% cost as a charity that Arjun and their team is providing to Wills Global. In addition, all the Wills visit, they're giving 10 rupees back. So really, because with the usage, the marginal cost of operating becomes less and less. So they realize that and they give it back as a charity. So that's how we are self-sustaining and self-funded growth model that we are able to create.
Okay, thank you. Yeah, I'll let somebody else if they have any question. Sure. I'll come back. I have another question. I'll come back later.
Sure.
So Raj, Dilip has a question. How do you select villages?
I'm sorry. The villages are created through the Gram Panchayats. We go to the state and areas. First of all, our first contact is the local organization. They will ask us. For example, RDT asks us. For example, Smart Village program, which is operated by Ambassador Kapoor, they ask us. So NGO, then Rotary, Delhi, we were planning to do that. They will come and then they decide which villages they choose. There are many times they contact Evolco that this village really needs the services. If they can provide, then and if they are in the need, we support and do it. The important thing is the village that is selected has no facility. If they have medical facility, if they have a doctor there, then we do not go there, because then it becomes a competition, unless that doctor wants to be part of the program and want to expand his practice, and if he wants to give charity service. So one important lesson that has been learned is that you don't go in the area where there is facility available, and you don't compete with the local doctors, and you don't compete with government. If there are many areas, primary health center, so-called ASHA worker, Anandwadi, some midwifery services, we want to support them if they are willing, but we do not want to compete with them, because then it defeats the purpose. Our purpose is to bring access where there is nothing. And finally, of course, if one of you says, here is $100,000, I want to create 100 villages in this area, that's where we will go. The place, and that is no bar, no barrier. So that is the third, how we choose, that's the third criteria. But to me, the most important criteria is if any of donors, when donor wish, and by the way, all the donations, the donor can specify they want to give it for healthcare, or they want to give it for water, or they want to give it for education, or and 100% of that donation is used to provide the support of that choice. So if you donate $10,000 and say, I want these 10 sites, we'll do it in those sites. So that's the most important to me, to expand, because after all, it is the donor's wish. That's what gives the donation, and that's where we create. So that's how we choose the villages.
The floor is open to all the questions. Anyone have any questions, discussion? Why don't you go ahead with your second question?
Yeah. So I was going to ask Lava and Sri Sai Healing Trust, should we pick some villages from the ones that we have to try this model? Lava, what do you think?
Uh, yeah, sir, we can, in fact, since we have got the complete briefing now on their operations,
Yeah.
we can look into it and see how we could be associated and see how we could be part of their expansion also.
Yeah.
And fill in the gaps, you know. But I had a small clarification from Dr. Raj. The operations, yes, this is the procedure you're following, but anything we have, you people are so not part of the medicine. How does it take place when you
Yeah,
prescribe the?
Yeah,
Yeah.
that's a great question. How we give them prescription, and we leave it to their discretion how they go and get the medicine. They can go and get the medicine. Certain low income people from primary health center area, they can get the free medicine. They reach certain pharmacies, they distribute medicine and charge their whatever Aadhaar card amount. But it is up to the villagers. We have not created a medication distribution. We are thinking, once we have experience over next several months operating this, we can then incentivize, like right now, the Sahayak gets about 30 rupees for each consult or each screening they do.
Right.
We can incentivize and say, look, why don't you have maybe once or twice a week, you go to the center and collect the medicine for all of them, and they may pay like a 5 or 10 rupees or something, but collectively it could be small amount which can be used for their transportation and to do that. Now the other thing so that is one way we are thinking. We have not operationalized that yet. Second thought is that there are many mobile uh, organizations which has mobile van which goes to the villages once a week or this. We can we can cooperate with them. We can uh, shake hands with them and say, look, these are the villages, these are the prescription. When your van visits that, can you take this prescription and distribute that? That's just a thought. Um, uh,
Exactly.
so
I
so
think I think we came to the exact right, the bridge meets the point. Like like Mr. Sundar said, we also have a mobile clinic bus
right,
where we go to. And one more thing about Silent Trust is wherever we start a medical healthcare support, it's on a weekly basis, because we believe that there should be a follow up done. Otherwise, this whole
right,
idea of doing the operations is not effective. So we go to villages weekly basis, a fixed time and date, and we prescribe medicine. I mean, the doctor sees, prescribes, and then we give the medicine for free also. So that's where we could also look at things, because the whole topic, this topic started by saying that we are trying to reach, the Wheels Foundation is trying to reach the most interior places where there is no facility, right?
yes,
So even for the medicine, that concern will come up, where they might have to travel to X kilometers. And at least in South India, what I see in Tamil Nadu and other places, most of our patients are senior citizens, either disowned by the kids who are staying in the cities, metropolitan cities, or even the kids are into some small wages, daily wages, or some kind of farming or whatever it is. So that's another area which we can, like you said, look
yes,
into, so that
right,
it becomes a complete effective model, you know.
right. We have done we have opened 4 sites, 4 village sites uh, through Bhakti Vedanta Charity Trust. They operate. This is Hare Ram Hare Krishna mission in Mumbai, Bhakti Vedanta, and they serve villages in Maharashtra. And I don't remember the names of those 6 villages. They have 4 vans. Up till now, they were using vans. Every week, they will go to a certain village. But again, it was only episodic. So what they did, they added telemedicine along with the van. So van can do and deliver the things. At the same time, the doctors who are actually going in the van often can right even from the van can do the service, and van doesn't have to travel to that village to do the teleconsult. So that hybrid model was created. Unfortunately, it was created in January and February. It was not operative because of lockdown, and they have just started doing that. So we'll have some experience in that going down the line.
Yeah, I have a question. This is Sudarshan and Asha from Seattle.
Hi,
So just
Sudarshan.
hello, sir. So I may have missed part of your discussion, but extension to the question about the medicines, is there a network where, like, if we do telemedicine and a patient comes who's in urgent need of help, so how do we refer that patient to a hospital or a care center where they can get their urgent treatment?
Yeah, the doctor on the telemedicine side, on the other side, who is doing teleconsult. First of all, we can print out the prescription because we give the printer at the village site. They can print out the printer and report, and then patient actually makes their own arrangement to go to the site. During the COVID, I don't know whether Uttar Pradesh, this is one where I had a direct meeting with the health secretary, and they immediately approved this, because even in primary health center, unless that primary health center doctor puts a stamp, they don't get the medicine or the testing. But now they have allowed our doctors, tele-doctors, to refer, and patient doesn't have to wait for them to be again stamped by the primary health center doctor to provide, so they can go to the primary health center and collect the medicine or get the testing done. So this will be an issue I don't have the answer, but one of the things is that, remember, government facility exists, although they're not always manned by the, not always have a doctor or other facilities. But in India, primary health center are there in for serving 30,000 population one. They may not be close by, etc., but that's where people are supposed to be getting the care. We are trying to extend that and bringing it to patients' doorstep. And of course, the logistics of delivery of the supply remains an issue.
Thank you.
If you were on our healthcare infrastructure webinar moderated by Arjun Malhotra and some of the great speakers that we had yesterday, one of the things Arjun mentioned, the program they have created, this was the same even for the ASHA workers. They go walking from one place to another. So they asked a two-wheeler company to donate. They donated 6 two-wheelers. They're providing midwifery and maternity services. So now that ASHA worker has a two-wheelers on which they can travel and covers 10 times more than what they were able to do that in a week. So there is something else that needs to be kind of a down the line ad where obviously getting two-wheelers and that becomes a hugely capital intensive program. But I'm sure once we have one step created and people see the need, we can get the donations for that. So that's
Great.
a tall order,
Mhm.
but you are absolutely right. Infrastructure and the way to deliver is still an issue that we'll need to answer. But I thought the first step first is just to find out whether they need anything or not. Find out and take care of the urgent problem if we can take care, etc.
Great. Thank you for all your efforts in this.
Thank you. So, Dr. Surya, what is your special? Are you a medical doctor or? We can't hear you, Dr. Surya.
Can't hear you.
Can I go next to the question?
Sure.
Hey, this is Rachna. Sorry, I joined late, and so I missed a bunch, so maybe you answered this already. But I'm wondering about the relationship between the patients and the facility that's being there. Like, are they going to know that if they go on a particular day, they'll see a particular doctor, and then, if they have to go, for a follow-up, are they going to get the same doctor, and do they know when to go to get a follow-up? So they have some history, and are there any metrics around, I forgot how many people you said have been to the centers, but how many of them are repeat patients? So they're establishing some sort of trusted relationship with this facility?
Okay. The facility is not brick and mortars. Facility doesn't exist. It is the home, if you want to call it, or the villager who has been trained to be helper or sahayak or telemedicine operators. It's in a little bag which has a cell phone and the vital sign measuring devices. So patient can, and they're living, we are not sending somebody. We train the local resident of the center. So, or I shouldn't say center implies that there is something existing. So relationship is between that individual and the patient. They come, they get all the history, they can get all the vitals, prepare the things. The software is very inclusive of all the, not just the medical, but all the socio-economic determinants of the health. All parameters, all the data points are collected during patient's history taking by the telemedicine operator. They are not medical people, but the software created actually is with the algorithm and symptoms based. So if they say I have fever, then it will automatically ask the subsequent question. A doctor will ask in that natural way to come to get the most information, and that builds up. And at the end of it, when the report is created, doctor only see the positive finding, not all the 20 different yes no question. And that's how we build up. So we have a built-in all the common 300 plus symptoms on which history part is done. Now the doctor at the other end, there is no relation between patient and doctor. It may be depending on who is available takes that teleconsult, but the doctor who actually sees the patient, doctor always have access to the history part or whatever is done from the previous visit to to give advice, see the patient and come to the diagnosis and advise the patient. This is similar to like we have our own practice, and then even in our group practice, one doctor may be seeing the same practice, but if that doctor is not available on the weekend or on vacation, the other doctor takes over, but that other doctor has the access to patient's chart and information. Here in the hospital, let's say RDT hospital, in their outpatient, on a regular basis, they see maybe 100 patients a day. In addition, there is telemedicine, so it's kind of a goes between the doctors. So there is no consistent one doctor, one relationship. If I answered your question.
Okay, thank you.
Sure.
Dr. Raj, can you hear me now?
Now we can hear you.
I think I got double muted on my headphone somewhere. I figured it out. I'm a PhD in metallurgy and material science. I switched my field and become an IT professional for the past 20 plus years. I work for the AT&T currently. So I did meet Sushil a couple of weeks back in the IIT annual picnic. So he briefed me about this. I have been thinking, and I wanted to know more about this Wheels Foundation and your efforts to do this telemedicine stuff. So now I got a good grip of it. I requested for the recording also. I wanted to share this information among my friends and family, and I wish I can influence at least few heads to come forward, either individually or collectively. Maybe let's see how much we can do.
Sure.
I'm happy to see the tremendous work being going on, and I wanted to be part of it by volunteering and contributing and whatever possible.
Thank you.
That's
Thank
very
you.
good. Thank you.
I'll just say that my goal when I set in January before COVID donations we got was 100 sites in year 2021 and 1,000 in 3 years. When I got the kind of support in last 6 months, we went from 30 to 300. So now my goal has increased to 1,000 sites 2021. And I think with 1,000 sites, on average, we'll see 10 patients a day. We're seeing 100,000 patients a day. That is 3 million a month, 36 million a year. That's the impact. Now, even though we are not providing a complete health care, like taking patient diagnosis, treatment, medicine, but we are providing the first step towards their health care. That's number one. Number two, we are also diagnosing not unknown, but patients not aware of their condition, like very simply taking their blood pressure and doing a finger stick blood sugar. Patient do not get symptoms till it is late for hypertension or diabetes. We just diagnose that. And if we can institute treatment, it's a tremendous impact in the long term. So third, we are also collecting the socio-economic determinants of healthcare, like a water supply, sanitation. Are they using chula or they are using gas? Because if those who are using chula, they're going to have smoke causing pulmonary lung conditions. We can, and then with this data, we can then give this data to the government, to the local people to do something. And you can see this is where our present government under leadership of our Prime Minister, if you listen to his 15th August, he says water, more than 1 lakh 1 lakh villages, because we have 600,000, 6 lakh, 1 lakh villages now have water supply through the pipe. That's a tremendous, and that has a great appeal for health. We have the housing. It's a tall order to provide a good shelter, which will go a long way. Then food, agriculture, the nutritional food, because all these are needed for healthcare. Health is not just merely the physical health and taking care of disease problem. Health is to create, by WHO's definition, to create a state of well-being, physical, mental, and socio-economic. That's a total health. We only are touching just one small part of that. WHILS and many other organizations are doing fantastic. For example, we have some, I forgot, they're doing in agriculture. When you produce, a farmer, give them the tools, technological tools. It could be very simple tools to produce and improve the productivity, that grain that supports the salary, supports the farmer, that food that is produced, giving nutrition to people, that provides health. So it is water, food, sanitary. We need education. Just simple hand washing is so important for personal health. You don't need technology. We need to have them provide the way so they can afford to buy soap and have water to wash.
Raj.
So my friend, the healthcare is such a huge subject. The WHILS is touching only the first part of it, and with the support. And again, this is a volunteer organization. WHILS doesn't go out to earn money. WHILS depend on you, the generous donors. You know, we all have been fortunate. God has given us a lot more than we need. And I think when we die, we're not going to take it with us. It has to be either be taken away or used, whatever it is. So maybe we can share. And remember, all, particularly those who are educated, all doctors. Our medical school education was highly subsidized. Maybe you paid a fee. My total fee was less than $100 for all 8 years of education in Baroda. Less than $100, equivalent today. It was 80 rupees for one term fee. Now, was it that cheap? No. Taxpayers were paying money. All IITians, Indian Institute of Technology, they're all supported by Indian taxpayers. So yes, I'm saying American community supports and brings me, I owe it to them. I would do for them, but we also owe something there. So as a great human being, if we can do something, hey, it'll give you that joy of doing it. But for most part, our millions are actually only CV is on our statement, and we feel happy about it, but somebody else is enjoying it. So I'm sorry I got into this, but Sushilji has the last word. I'm sorry I took a little longer time to mention about it. Go ahead.
I want to thank everyone for attending it. I think we made a very good presentation. And just one thought I had, parting thought, the goal that we had for 1,000 sites by end of the year, we should have goal maybe 3 years or 5 years that every village, 1,000 people or more, should have a facility, primary facility like that you're providing. By let's select the term 3 years or 5 years or what. Let's make it ambitious. Let's set it 3 years. Every village should have a primary healthcare facility. They should not have to travel more than 5 kilometers.
Right. And Sushilji, just on that note,
Yeah.
if I can get the 500 to 1,000 sites,
Yeah.
which is very much within our goal, I am I'm assured that as soon as we have that data of impact, our chairman Rajat Gupta, who is also on the board of advisory board of Gates Foundation and other, they will take this. We will get millions. They will be, but before they will look at this, look at our organization to receive that kind of a donation, we need to show them the people, the resources we get, and how we are using, producing the maximum bang for our bucks, maximum impact for the dollar that we spend. And then I think that there is a lot of money available if just for the right cause, for the right reason, and in the right way. Because I know many people are burned, even some big organization like United Health, United Way and this, where 50% of the money goes in the pockets of administrator. Here, zero. I give 5,000 to 10,000 every year to support our causes and run the organization. That's the kind of organization this is. So this is definitely should be worthy of your donation. And I think some of you who are in companies like AT&T or Microsoft or Adobe or Apple, your donation becomes doubles or triple. I think Cisco triples the donation. If you give $1,000, they'll give $3,000. It becomes 4,000. So these are many different ways we can help and come to that. Thank you, Sushilji. And thank you very much, all of you, for spending their Sunday morning breakfast listening to this, where instead of you getting served breakfast, you are asking to give something. So thank you.
Raj, we'll have a call separately to get you prepped for the conference.
Sure,
So
I look forward to Sundar.
Okay, and then collaboration is very important. So working with the Sai Healing Trust, I think we can expand the reach.
I look forward to.
Yeah, thank you. Thanks.
Thank you everyone for attending. I think I'll send an email out if you want to form a group, email group or WhatsApp group, so we can complement each other. Next week we can accelerate the reach to everyone else. Okay, any other thoughts you may have, please feel free to share with me. Okay. Thank you very much.
Thank you.
Thank you, everyone.
Thank you.
Thank you.
Bye.